Hello everyone, again I welcome you all to my lecture class. In my today's class, I am going to talk about reactive arthritis, and at the end of my class, I am going to talk about the possible multiple choice questions which might come in during your PG entrance examination. Reactive arthritis is an acute non-purulent arthritis complicating an infection elsewhere in the body, not in the joints. This is a spondyloarthropathy which follows an enteric or urogenital infection, and the responsible organisms are Shigella, Salmonella, Yersinia, Campylobacter species, or Chlamydia trachomatis. The pathophysiology is not very much well understood, but there is a demonstration of triggers attacking mucosal surfaces, invading host cells and surviving intracellularly. There is also demonstration of bacterial antigens in synovial tissue. In the clinical features, the patient may present with transient monoarthritis or enthesitis, or in severe cases, the patient may present with multisystem disease also. And typically, there is a history of antecedent infection, may it be GI infection or urogenital infection, within the preceding 1 to 4 weeks. The patient will have constitutional symptoms like headache, malaise, fatigue, fever. Arthritis is usually asymmetric and usually additive. The common joints affected are knee, ankle, subtalar joint, metatarsophalangeal joints, and interphalangeal joints. And dactylitis or sausage digit is one of the common manifestations of reactive arthritis. The patient will also have enthesitis, as we have already mentioned in other classes. This enthesitis is the inflammation of the site where tendons or ligaments gets attached or inserted into the bone. There will be sign or symptoms of accompanying urethritis or prostatitis in male, cervicitis or salpingitis in female. In the extra-articular manifestations, the patient will have conjunctivitis or uveitis. There may be oral ulceration. There may be keratoderma blepharogica or succinate balanitis. Less frequently, there may be cardiac conduction defect, aortic regurgitation, or nervous system involvement, or pleuropulmonary infiltrations. In the diagnosis, 30 to 50% of the patients are HLA-B27 positive, whereas we have discussed in other class that in ankylosing spondylitis, almost 90 to 95% of the patients are positive for HLA-B27. The markers of inflammation will be raised. There will be raised ESR, CRP. In the complete blood picture, we may find mild anemia also because of chronic inflammation. In synovial fluid analysis, there will be non-specific inflammatory findings. There may be serological evidence of exposure to triggering organisms. In the X-ray, we may find X-ray of the involved joint, we may find juxta-articular osteoporosis, marginal erosions, and loss of joint spaces. Periostitis with reactive new bone formation is quite typical for reactive arthritis, and there will be sacroiliitis and spondylitis. If we talk about the treatment, we can use high dose non-steroidal anti-inflammatory drugs. Chronic reactive arthritis associated with Chlamydia trachomatis or Chlamydia pneumonia can be treated with rifampicin, azithromycin, and doxycycline. Among the disease-modifying anti-rheumatoid drugs, we can use sulfasalazine, azathioprine, or methotrexate. These are disease-modifying anti-rheumatoid drugs. So this is in short about reactive arthritis. Now, if we talk about the MCQ, multiple choice questions coming from the topic of reactive arthritis, the questions can be like the commonest organism which is associated with reactive arthritis, both in India or globally. There may be question on keratoderma blepharogica. There may be picture of keratoderma blennorrhagica and you might be asked what is the lesion, and there may be question on Sarsenet balanitis also. So these are the few important questions from MCQ point of view which you can remember. Thank you.